I'm Harriette Van Spall, clinical trialist, and I'm here with Jasper Brugts from the Netherlands at HFA 2024, where he is presenting his registry of heart failure GDMT optimization. Welcome, Jasper.
Thank you. It's a pleasure to be here.
Tell us about your registry. Why did you initiate it, and what were you hoping to achieve with the data?
So we initiated the TITRATE-HF 2 years ago after the publication of the ESC guidelines for heart failure with the class 1A recommendation for 4 types of drugs. And we wanted to study how those drugs are implemented in real world. And we developed a rather large study to study de novo heart failure and chronic heart failure and worsening heart failure all together.
Okay, so 3 patterns of heart failure. What were your inclusion criteria for the registry?
So for the de novo, it must be a new diagnosis of heart failure without previous heart failure. And we only studied patients with an ejection fraction below 50%, so no preserved ejection fraction. And the same is true for chronic. That should be at least 6 months of heart failure. And for worsening heart failure, there must be a heart failure admission during the past 6 months. So we identified, according to the ESC definitions, the 3 relevant groups in heart failure.
Sure. And tell us how you went about engaging clinicians to participate in this registry. That's often a barrier to these registries. So how did you mobilize the energy and the resources required for this?
That's a correct point. It is always difficult to provide enough attitude and vibe to do a registry. And we managed to include 48 hospitals, which is nearly 70% of all Dutch hospitals in our country, through partnerships. We had many partnerships with the Dutch Cardiac Society and the Cardiovascular Alliance and our Netherlands Heart Institute to really boost this registry for a national prospective effort in optimizing heart failure care together with each other. And we managed to do that in about 1.5 years. We included 4,000 patients.
That's fantastic. What were the baseline characteristics of these patients?
So the mean age was around 70 years of age, which is slightly younger than expected in a real-world population. I think the mean age is about 75 in our country. And about 30% was female. And the average duration of heart failure was 4 to 5 years on chronic and worsening heart failure. With all the de novo heart failures were, of course, new in their diagnosis.
Okay. And what were some of the comorbidities that your patients had?
Many had diabetes and renal insufficiency and atrial fibrillation. About 30 to 40% had multiple comorbidities, 3 or more.
And what were some of the leading causes of the heart failure?
So we observed for the de novo category that 60% had non-ischemic and 40% had ischemic. And in the chronic heart failure, it was more balanced, 50% of both categories. Yeah.
Okay. And did you look at any sex differences in the baseline characteristics?
Not yet. At this stage, it is only a cross-section of first data from TITRATE-HF, but in the coming years, we will really dive into elderly, female, comorbidity to really unravel the gaps of knowledge in current heart failure care. Yeah.
Sure. So tell us about your findings on the uptake of guideline-directed medical therapies across the 4 classes of treatment.
So for chronic heart failure patients, 85% were on renin-angiotensin system inhibitors and beta blockers, and about 75% were on a mineral receptor antagonist, and 65% on SGLT2 inhibitors. So that's quite an appropriate level of guideline-directed medical therapy. And we also assessed difference between hospitals. And if you look at quadruple therapy, this of all 4 drugs at once, you see quite some variation between hospitals, from 25 to 75%. And if we study how those patients were treated at the outpatient clinics, we saw a quite remarkable difference between general outpatient clinic versus heart failure dedicated outpatient clinics, where in the general it was about 37% quadruple therapy, and in the heart failure outpatient cares it was 47%. So clearly, I think the level of dedication in outpatient care also helps implementing guideline-directed medical therapy as well.
Sure. And are your outpatient clinics multidisciplinary, or do they tend to have physician predominant services?
In the Netherlands, we have a nurse-led heart failure outpatient clinic.
Okay.
It's not multidisciplinary. There is a supervisor heart failure specialist, and a nurse. That's how we are organized in the Netherlands.
Got it. So the uptake of therapies was better in that type of care setting.
Yes.
Fantastic. Now tell us some of the barriers or limitations to the implementation of these therapies.
So what we really observed was also side effects were really relevant, and intolerance of drugs, but also reasons not to uptitrate, like the blood pressure and the pulse and the side effects that patients encountered. That's something that we managed to describe in detail for those patients where it was marked in the electronic healthcare records. One of the pitfalls of registries, but also in general, is that usually it is not even recorded why patients are not uptitrated to target dose. That the electronic healthcare records is not giving you that information. So we encountered the same problem as well. Yeah.
Sure. So there were real limitations to the uptake of these therapies. Did you find that patients with those limitations were more prevalent in the generalized settings versus the specialized settings, though? Or did you look at that? Did you look at setting versus limitations?
Not yet, but that will be up for the upcoming analysis for sure, where we also have prospective data, as this is only the cross-sectional first part of the data. But for the coming periods, we have long-term prognosis, look at side effects, especially in the de novo category. We follow them for 6 months with every titration step, and every dose needs to be recorded in a log file. So that will unravel new data on the upcoming medical congresses in the coming period.
So across the world, we see variation in the uptake of certain classes of therapy. Which class would you say had the most adverse effects or intolerable side effect profiles that limited therapy, and which one was the easiest to deliver or adopt?
Yeah, what we see for the data that was available in a small set of patients, that you see that in the ACE inhibitors and beta blockers, most of the intolerances occurring. And I think for the easiest is by far the SGLT2 inhibitor. And what we really see is that at this moment in the Netherlands, about 50% of the patients is on sacubitril/valsartan, and already 65% is on SGLT2 inhibitor. So the uptake of the SGLT2 inhibitor has gone faster. Well, it is only recommended for a few years now, and the sacubitril/valsartan is from the 2016 guideline.
Of course, and there are other issues about cost, access, one dosing versus need to uptitrate, and then the side effect profile as well. And then MRAs, you had quite a high prevalence of hyperkalemia with the use of steroidal MRAs. Tell us about that.
So what we encountered is that about 30% of all side effects that were noted, so that's of course the limitation, were due to worsening renal function or hyperkalemia. And that's really real-world evidence, and the practice that we encounter with spironolactone or eplerenone. And for these patients, it was the reason to stop the drug. And I think that's relevant practical data, that it is a problem in real world as well.
Okay. So across these settings, you found greater uptake of medical therapies in specialized centers that were nurse-led, and you found that side effects were a limitation to the uptake of therapies. Overall, what have you learned that could be actionable in the care of heart failure? And what are your next steps? What do you plan to do as a next step with this data?
Yeah, I think that it is really essential data that we have here. Also for the upcoming analysis, we will check what happens in time. This was one snapshot in time, but we will see how the implementation is going in those patients with de novo heart failure, and we will learn what are the implementation barriers for the new drugs to those patients with de novo heart failure. And I think that that will also be a lesson that the first initiation is where the most important steps are made. So in the first few weeks, just rapid uptitration with all 4 drugs in a relatively low dose is the way to go forward. Yeah, and I think the best strategy would be to do a test or an implementation randomization within a de novo heart failure group to see how we can facilitate and improve GDMT uptitration in those patients within the registry itself.
Right, when they're earlier on in the disease stage and they have more reserve, less likelihood to have intolerable side effects. Thank you so much for being here and for sharing the results of your registry with us.
Thank you.